You mentioned to us like 7 drugs already between yourself and Amit. Like, how are we going to choose?
There's different ways to do that, obviously, and one way, the more painful way, is for every single patient go back and say, okay, would that patient fit the eligibility criteria for the respective trial? Did the patient benefit for many, many months in sorafenib? Or you try to choose the drug that has the least restriction on eligibility, and you're not going to be wrong. Some people might say switching the mechanism of action might be a way to do this, from going anti-VEGF TKI to an IO, but I think the data will lead us. We have 2 negative randomized phase 3 trials with single agent IOs versus placebo or sorafenib, as you showed. But we have 3 positive anti-VEGF second-line trials. So I don't think the hypothesis that switching mechanism of action necessarily will be a guiding principle. So I look at the patient, look at the underlying liver function, performance status, what was the prior treatment, what was the toxicities, and then together with the patient we'll make the decision. Most of the time, probably if I need disease control rather than have the luxury of time to wait, I'll go with a drug that gives me a high disease control rate, such as cabozantinib, for example, 67% range disease control rate initially. But if you go with an IO, that might drop to 30% or so. So that becomes another way to look at this.
I might challenge you here. And of course, by all means, I totally agree that we have, or we might have different perceptions in regard to the disease. If anything over here, and especially if I bring in what Riyad just mentioned about, like, okay, I'm available, if things are stable, I might really revisit things one way or the other. And as such, I probably agree with you that response is key. But at the same time, I would like to really revisit the 2 phase 3 trials in regard to the pembro versus placebo, and of course the nivo versus sorafenib. Yes, they were negative, but at the same time, though, it was not like they were disastrous. They did not show the primary point, and I still stand by that a anti-PD-1 by itself does not work in the disease. But at the same time, the response is very critical over here, as it was already seen in the phase 2 data that we have. And as such, I would like to go back to Amit and say, do you think anything goes wrong here if, for example, we give our patient here who got lenvatinib, progressed on lenvatinib, we give them pembrolizumab?
I don't think there's anything wrong with it. I agree with you that at the end of the day, when you take a look at the Keynote trial, I mean, it's a negative trial. But when you then break down the data, I mean, you take a look at this, and there was a benefit there. It's just that it wasn't statistically significant because there was 2 co-primary outcomes, and they looked at the data early. At the end of the day, when you take a look at the absolute survival, there is a survival difference, and there is differences in terms of the responses. So I do think that IOs play a role in the management of HCC. And so I don't think it's wrong to use it in the second line, particularly in somebody who progresses on lenvatinib. I think that, Farshid brought up points of like how that patient does on lenvatinib. I think if somebody, for example, doesn't tolerate TKIs well in the first line setting, I'm much more likely to use, immunotherapy in the second line. If they go through it quickly, if they basically have disease progression in, 3 months, then I'm much more likely to use, a checkpoint inhibitor in the second line. I think they play a role. I just don't think that there's one drug that goes for everyone. I think that right now it'd be nice if we had something that would make us smart in terms of choosing. It'd be nice if we can actually have, molecular pathways that were like, if your tumor has this pattern, we would use this drug. We don't have that right now, and so we have to use, clinical characteristics that got you into the trial, or these other clinical factors like how quickly you progress on the therapy and drug tolerance.
I totally agree. If anything, at the end of the day, the anti-PD-1 checkpoint inhibitors in the phase 3 trials did not really show the improvement in survival, but the response definitely data is there, and if anything, they are available and they are already approved for that purpose. Nonetheless, we're going to come to hopefully other, we'll see what our colleagues have more cases to discuss in our tumor board, but if anything, the combination of the checkpoint inhibitors plus TKIs, or even combination of checkpoint inhibitors plus checkpoint inhibitors is really nowadays is a very hot subject. And the idea is that if an anti-PD-1 by itself cannot do it, and please do understand that an anti-PD-1 in HCC is not like an anti-PD-1 in lung cancer or melanoma, but if anything, if a combination of anti-PD-L1, for example, plus anti-CTLA4, or if an anti-PD-1 plus a tyrosine kinase inhibitor or anti-angiogenic will make it, we'll just have to wait for the data. I'm sure we'll have more cases to discuss about all of those combinations that we're coming, waiting eagerly for the results of.